of Anesthesiologists. We are delighted to have you partake in this important webinar concerning the PCPNDT Act and its implications for therapeutic care as we explore the associated challenges and potential solutions. Now we will listen to Kaho anthem. Over to you, Nisha.
A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together, a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, walk with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together, a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Very good evening, everyone. It's a great honor to welcome Dr. Sukhminder Singh Bajwa, a renowned anesthesiologist, academician, and researcher of international repute. With over 15 years of experience in editing and reviewing, he has authored more than 430 publications, contributed 8 book chapters, and played a key role in developing 7 national guidelines. He has held prestigious editorial positions, including editor-in-chief of Practical Evidence in Anesthesia Knowledge, and served on board of over 30 scientific journals. Currently, the Honorary Secretary of ISA National for the period 22 to 25, Dr. Bajwa's leadership has significantly contributed to anesthesia practice and research in India. His contributions have earned him numerous national awards and global recognition, including being listed among the world's top 2% scientists by Stanford University in 2024. We are privileged to have Dr. Bajwa with us today, a true pioneer and inspiration in the field of anesthesiology. A warm welcome to you, sir, and over to you.
Thank you, ma'am Dhanya. It's a privilege to be part of this August gathering where we have joined hand with KAO. This ISA KAO partnership is going to have a long-term association where we are concerned with the patient safety. I've gone through that book of the patient safety recently, handled to me by Dr. Bala sir on the during our Trivandrum visit. And it's, I think that's the way to go forward in developing the patient safety guidelines from all aspects. It's a holistic approach we have to adopt going forward. Now, coming to this part of the webinar, I think the topic is a very relevant topic, the PCPNDT Act. Right from the time since it has come, I'm not that much a medical legal expert, but as an anesthesiologist, as a clinician, we know the limitation of our working domain under this act. When it was enacted, it must have been because of some prevalent noises in the society. It must have been done by the policymakers to make it more, aggressive to curb those nuisances. But the way our modern science has evolved, the way our research work, the way our patient safety factor, the way the medical legal litigations are going forward, I think it is a time to rethink about the various sections of these acts. How can it give a selective freedom to the core clinicians so that they can build upon within the purview of the this act how to go forward in their educational research academic purpose so that it can be utilized for the betterment of humanity. For the last few years, what we have heard, what we have listened, what we have got the feedback from our various anesthesiologists as well as the critical care physicians is that there are certain things of the acts which limit its widespread usage in our clinical field, where really the freedom is required for the progressive growth of our science. I think some limitations are there beyond which we cannot go. Although we have formed a legal expert committee in our ISA now, and the idea of this webinar is to take forward to have a white paper presented to the government of India, to the health ministry, with the president of ISA will always be there in the Niti Aayog. So many things will be there, and KAHO itself is a association which is taking large leaps in the patient safety, uh, this campaign. So I think it's a right platform where we can discuss upon the various parts of this act, and also the suggestions like to bring the PCPNDT Act into the anesthesia curriculum, to our postgraduate curriculum, so that everybody should be very well aware of this act. And this, the limitation of these acts should be known to almost everyone, so that it should be misused, no, should not be misused by anyone. And going forward into the research academics with the ultrasound usage, as well as the other parts of the PNDT Act, I think we have to be a very, very meticulous in going forward, taking our case towards the government agencies of each individual anesthesiologist, critical care physicians, pain physicians. So many specialties of anesthesia have spread their wings where we are using the USG especially, and where the PCPNDT Act can curb certain parts of that treatment, which could be very beneficial to the patients. So, considering the for the betterment of humanity, this type of regulation, because when it was formed, the regulations were different, the society structure was different, the advancements were different. It's almost 2, 3 decades now, although it has gone modifications in between. But with the current progress, it may has not the how to keep pace with the current progress in the medical sciences. I think this act really needs a review. The task force have to be created. I think that is a right place. This webinar, this platform is a right place to form another task force where we can represent to the government societies, where we can uh, take our case to the extremes so that we can use the various section of this act for our betterment of our patient care as well as the research academics to take it forward. And I liked this with welcome address to our president, welcoming president, our Dr. Bala Venkat sir, president-elect Dr. Naveen, then our treasurer, Dr. Manoj, and GC members, all the GC members here, and especially Dr. Lalu Joseph from KAHO and her team. And we're really very motivated by your KAHO anthem, and I think it's the right time for we also should have a anthem of our ISA should be played at every conference, every zonal function. So that's what's going through my mind when the KAHO anthem was being played. So thank you everyone, and I just hand over my mic to Dr. Bala as a tradition of ISA. Dr. Bala sir.
Thank you so much, Dr. Bajwa. And that was a good welcome address. And I hand it over back to Danya to take this forward.
Thank you, sir. We are delighted to welcome Dr. Lalu Joseph, a true leader in healthcare quality and patient safety. As a quality manager and associate general superintendent at Christian Medical College, Vellore, and Secretary General of KAHO, she has led numerous national initiatives to strengthen hospital accreditation and training. A proud recipient of prestigious awards, including DL Shah Award, BMJ South East Asian Award, and ACHSI International Medal. Dr. Lalu is also an ISHQA expert and serves on several national and international healthcare bodies. It's an honor to have you here. Over to you, ma'am.
Thank you so much for that, Danya, and I truly appreciate the partnership between ISA and KAHO. We believe in collaboration. We cannot function in isolation. It is the need of the hour that all of us come together to address the concerns of patient safety and improving efficiency and effectiveness in the healthcare delivery ecosystem. The PCPNDT Act, as Sir rightly put across, is probably, was probably brought in at the time when the female feticide and promoting gender equality was at the prime. But every act that comes in has something that we will have problems with. Particularly, this act has a lot of issues when it comes to diagnostic and therapeutic benefits that can be provided to the patients, considering the limitations at the moment we have. So the time has come for us to sit down, work together, and understand the various nuances and trying to balance between what is needed at this point in time. So this webinar is really going to be a game changer, I'm sure. Let us openly discuss, deliberate, and come to a fine balance. And who else can do it better than ISA, the experts from the medical fraternity and also the legal fraternity. And I truly appreciate this partnership. Once again, thank you all for coming together. We are in this together, and let us start this with preparing a good white paper. We can certainly go ahead with preparing a consensus statement with probably having Delphi method adopted so that we can present properly to the government our concerns and the need. Thank you so much, and best wishes for a wonderful webinar.
Thank you, ma'am. And next, we are privileged to welcome Dr. J. Bala Venkata Subramanian, a distinguished senior consultant anesthesiologist based at Ganga Medical Center and Hospital in Coimbatore. He holds a prestigious position of President of Indian Society of Anesthesiologists and serves as a secretary for the World Federation of Societies of Anesthesiologists. Known for his visionary leadership and unwavering commitment to ethical clinical practices, Dr. Bala is a respected global authority in the field of anesthesiology. His dedication to advancing the profession and advocating for the best practices make him a vital force in the medical community. We are proud to have you, sir. Open to you for the floor.
Thank you so much, Danya, for that warm introduction. It's been the vision of Indian Society of Anesthesiologists for time immemorial to have ultrasound as a bedside tool for immediate diagnosis and management of several medical disorders, and also to utilize ultrasound for on-arrival blocks in trauma victims to start venous access, to start intra-arterial lines. So it's become very pertinent, and it has become inevitable that the best treatment could be offered to a patient without using this wonderful box, the ultrasound machine. And having said that, initially the know-how was not there, but now with the several workshops happening across the country, the anesthesiologist, the critical care physicians, the emergency physicians, all have acquired the skills of using this machine. So now the time has come to make this available to all those who wanted to do it. And thus ISA thought it's prudent to collaborate with the leaders in patient safety in this country today, CAHO. Thank you to Dr. Lallu Joseph and Dr. Vijay and the entire CAHO team for coming forward to collaborate with Indian Society of Anesthesiologists to understand everything about the PCPNDT Act, the ability of someone to apply for an ultrasound machine, what are the current issues, concerns, and how to represent to the government jointly on the need of this machine being used to prevent several morbidity and mortality. So we are extremely fortunate that we could get some of the best names in this field to address us today. And once again, on behalf of the entire Governing Council and members of the Indian Society of Anesthesiologists, I'm happy to share we are close to 50,000 anesthesiologists as members of Indian Society of Anesthesiology, and we form the fourth largest anesthesia body in the world, representing in WFSA. So we look forward for a very fruitful webinar today, and I'm sure at the end of it, we will have certain definitive direction towards accomplishing our common aspirations and goals. Thank you, and over to Danya.
Thank you, sir.
Thank you, sir. James, over to you, James.
Thank you, Dhanya. Now, we will move on to the first session of the webinar today. I would like to introduce Dr. Rishabh Kumar Rana, a distinguished public health expert and associate professor in the Department of Community Medicine at Shahid Nirmal Mathur Medical College, Dhanbad, Jharkhand. Dr. Rana's expertise spans advanced statistical analysis, research, and human resource management with a proven track record in vaccine programs, immunization planning, and public health surveillance. As a former surveillance medical officer with the WHO and technical officer for USAID's Vriddhi project, he has demonstrated exceptional leadership in coordinating with state, national, and international stakeholders. His role as a member of the State Inspection and Monitoring Committee for the PCPNDT Act in Jharkhand, along with his experience as Common Review Mission Public Health Expert in Tripura, as well as National Assessor for Effective Vaccine Management Assessment in Assam and Uttar Pradesh, underscores his deep engagement with public health policy and implementation. An accomplished researcher, Dr. Rana has authored over 40 publications in international journals and contributed to 2 books. Dr. Rana's practical experience and commitment to addressing critical public health challenges, particularly in the context of PCPNDT Act, make him an invaluable voice for today's panel discussion. We welcome you, sir, and over to you.
Good evening, everyone. Good evening to all sirs and ma'am. And I must say that I feel honored and privileged to be speaking in front of so big luminaries. In cricketing parlance, I can say I am just akin to the new kid, Vaibhav, and playing in front of MSD. Anyway, so first I would like to share my screen. My screen is visible.
Yes, sir, it's visible, sir.
Okay, thank you. So thank you again, CAHO and Society of Anesthesia for giving me this opportunity. And I am an associate professor, as Dr. James sir said. So moving ahead. It's a legal initiative without any confusion, PCPNDT Act. It was earlier in 1978, when Government of India issued a directive which said that amniocentesis should be banned. Any misuse of amniocentesis should be banned in government hospitals and labs. Then it was followed by 1988 Maharashtra Regulation of Prenatal Diagnostic Technique Act, the first state to do so. And then it was in 20th September 1994 when the PNDT Act was enacted, and it came forth in 1996 as the Prenatal Diagnostic Technique Act. Then again, uh, uh, further thing was done, and we can say that a new thing was added, the preconception. So the act was completely said as preconception and prenatal diagnostic technique act, and it basically was to provide for prohibition of sex selection after conception and for regulation of prenatal diagnostic techniques for the purpose of detecting genetic abnormalities or metabolic disorders. The main purpose of enacting the act was to ban the use of sex selection techniques after conception and prevent the misuse of prenatal diagnostic technique for sex selective abortions. And the act mandates compulsory registrations of all diagnostic laboratories, all genetic counseling centers, genetic labs, genetic clinics, and ultrasound clinics. I will come to the act details also in coming slides. And we can see that how Act number 57 of 1994, enacted by the Parliament of India, assented on 20th September 1994, when this act commenced in 1st January 1996. This is again the rough brief, outline following the dates. So President gave the assent on May 18, and then the act was extended across the country except J&K. There was an amendment in 2003 of the act on the act, and in this 2003 amendment, ultrasound was included inside the act. And at that time, in the amendment, it was mainly done to cover the bridging, covered bridging the techniques of preconception, sex selection within the ambit of act. Ultrasound was included, as I said, empowering the Central Supervisory Board, constitution of a state level supervisory board, provision for more stringent punishments. I will be showing those things in my coming slides. Empowering appropriate authorities with the power of civil code for search, seizure, and sealing the machines and equipments of the violators. And that is what makes the act so threatening, the appropriate authority. And that is what also what makes the act so problematic for so many clinicians. And regulating the sale of ultrasound machine only to the registered bodies. I think this is also like a regulation which was put into the act, and this is one of the bigger problems which I was seeing when I went over the various studies which have been carried out across the country on either the point of care ultrasound or ultrasound, etc. So this is coming straight from the Act. The picture you can see is from the Act itself, Chapter 1. You can see I've written the definition. Going through the definition, an act to provide for the prohibition of sex selection before or after conception and for regulation of prenatal diagnostic techniques for the purpose of detecting abnormalities or metabolic disorders or chromosomal abnormalities or certain congenital malformations or sex-linked disorders, and for the prevention of their misuse for sex determination leading to female feticide. So everything, as we all know, like it is for curbing the female feticide, which was at some point of time very rampant across the country. It is still debatable how much we have achieved, but definitely many studies have pointed out that PCPNDT Act has put a big curve in the number of female feticide which have occurred across the country, and definitely in some places the sex ratio has improved. So this act was enacted with the clear objective that we must help the female population in reaching their maximum potential across the country. Now, in this page, I have just marked the three boxes, the red boxes. And if you look closely, it is the reason why there are so many problems coming up. Like in the section 3A, there is prohibition of sex selection. So no person, including a specialist or a team of a specialist in the field of infertility, shall conduct or cause to be conducted or aid in conducting himself or by any other person sex selection on a woman or a man, as told, uh, and they should not disclose any gender. And then there is section 3B, which is prohibition on sale of ultrasound machine, etc. to persons, labs, clinic, etc. not registered under the Act. And it clearly says no person shall sell any ultrasound machine or imaging machine or scanner or any other equipment capable of detecting sex of fetus to any genetic counseling center, genetic lab, genetic clinic, or any other person not registered under the Act 1. And then you have got chapter 3, and you can see 4. Then there is the regulation of prenatal diagnostic techniques, and this again demands that every machine which is being used must be documented. Every place where the machine is to be used must be documented, and there should be no deviation from the documentation which the parties are giving to the government. And I think these three regulations are causing lots of problem when we go in the field, when we go as a member of appropriate authority in the field, or as I have seen in various studies which have been conducted in India, that these regulations are one of the, or being pointed as one of the major deterrent even in the use of emergency or the point of care ultrasound machine. Moving ahead, I will just say that, okay, I will skip this thing. So again the crux of the act. It is mandatory that the person conducting ultrasonography on a pregnant woman to keep complete record in the clinic. It is again a thing which is not being followed to the letter T. Any deficiency or inaccuracy found in records will amount to contravention, section 5 or section 6. There has to be informed written consent. According to section 5, no person will conduct the prenatal diagnostic procedures unless explained all known side effects or the after effect of the procedures to the pregnant woman, obtained a written consent to undergo the procedure in the language which she understands, and copy of her written consent is given to the pregnant woman. So these are again like the records which are to be generated, which are to be explained to the patient in a language which she understands, and these records are to be kept with the clinic or the establishment for at least 2 years. There are other provisions also other than the record keeping, that is displaying of the PCPNDT registration certificate by the
Sir,
yes.
Sir, just a minute, sir. Can
Yes.
I share the PPT, sir? I think the image is blocking it. Can I share the PPT? Can you stop sharing, sir? You can tell
Yeah,
me when
no
to
issues.
Yes. Thank you, sir. Yes, sir, you can go ahead, sir.
Yeah, let me have the screen. Yeah, I am seeing the screen. So display of PC. Yeah, as I was saying there, display of provision of determination of sex board, rule 17, availability of copy of the act, maintenance of the record for a period of 2 years. Role of a state medical council is also given in the PCNPNDT Act. It says that suspension of registration can happen if charges are framed by the court till the case is disposed of. Removal of the doctor's name from the register of the council on conviction for the period of 5 years for the first offense, or permanently for the subsequent offense. So these are very strict. Please, next slide. Let's move to the next slide. So these are very strict provisions which have been laid. Then there are penal provisions as well. Just summarizing them, and I have also summarized these in a tabular format in my coming slide. So metropolitan magistrate or first class magistrate will try any offense punishable under this law. Section 22 relates to prohibition of advertisement of sex determination. It is not to be done. Section 23 contravenes any of the provisions for this act or rules made thereunder shall be punishable with imprisonment for a term which may extend to 3 years with fine up to 10,000, subsequent conviction 5 years and fine up to 50,000. Then section 25 is also there, which again says shall be punishable with imprisonment up to 3 months or with fine or both. And there is, according to section 27, every offense is cognizable, non-bailable, and non-compoundable. So these are very grave provisions which has been laid down in the Act. And that's why we all know there are lots of problems coming up. Then there is these things like the register rule 9(1), form F, all case related records, forms of consent, sonography plates or slides, recommendation letters shall be preserved, rule 9. If records are maintained on computer or other equipment, printed copy of the record shall be taken and preserved after authentication by a person responsible for such records, rule 9, section 7, parenthesis 7. Send complete report by 5th day of the following month to the district like civil surgeon office or CMO office or whatever is there in the district. So this is again as per rule 9. So these are very sort of tedious rules which have been laid down by the Act. Please move ahead. And the thing is that all these things are laid down that ultimately will have the legal bearing of burden of proof by the doctor. The doctor will be responsible. He can't say that my staff is not doing like this, I won't take the responsibility. He can't say that, okay, I forgot to keep the records with me, I forgot to sign the records, etc., etc. It is assumed by the Act that all these things the doctor is going to be responsible. Then there is again the various laws in the Act relating to cancellation or suspension of registration. Section 20 deals with cancellation or suspension of registration. Section 20 parenthesis 1 complete contemplates notice. Section 20 parenthesis 2 explanation from center with regard. So many sections are there. I think someone was asking for the PPT. Please share it. Then there is powers of the appropriate authority. So appropriate authority is itself like it's an authority which is being misused also. And many a times even the High Court said that this appropriate authority was not framed properly. And when the appropriate authority is not framed properly, it means there is chances of corruption happening. So there is appropriate authority and it's a very powerful authority. And it can seize your premises, it can seal your premises, it can note any contravention, and it can then think are the contraventions major or minor, and then it can decide what needs to be done. So it's a very powerful authority, and as per the Act, it is there, and we have been to those authorities as the inspection members. So, and we have seen many contraventions being done by the clinic. So these are all there, and the Act has laid down provisions, and these are means the appropriate authority can come to you if your clinic is not doing things as per PCPNDT Act. Oh. So next slide, please. Yeah. Now I have just sort of compiled various forms. You can see so many forms of there. Just went the previous slide was about Form A. So Form A is like you apply. Then Form B, certificate of registration. This is to be hanged in your sort of displayed in your clinic, in a very prominent place where anyone can see that the license is still valid. Then there is Form C, which is rejection or for grant renewal of registration. It is also there. Form D, so many forms are there. It is form for maintenance of records by the Genetic Counseling Center. You will have to keep all these records for 2 years at least. Form E, for maintenance of records by genetic lab. So one was counseling center, this is genetic lab. Again, it has to be kept for 2 years because it's a record which is very important. Then Form F, it is again very important. Most of the ultrasound centers which were visited by the appropriate authority were not having the exact number of Form F which were scanned by the ultrasound machines. Like in those facilities, suppose we looked in the ultrasound machine and we found 32 records of the ultrasound being done. When we asked for the Form F, they gave only 2. So this is again very important form, and it is to be kept in proper recording store places and for 2 years. Then there is one more form, Form E. There is a second part of the Form F, where basically declaration of the pregnant woman is taken. And then we can move ahead. Yeah, this is a part of 25. You can see 25 points are there in the Form F. And Form F is to be accompanied by identity proof of the pregnant female having her address. And if unavailable during emergency, it should be noted and mentioned in reports to the district authorities as well. So it is very important form. Then there are more form. Form G. Form G is form of consent, where it should be Hindi in Hindi or local language as well. Because if the patient is saying that I don't understand a thing which you have written in English, what's the point of the consent? So this is again a tedious thing. And then there is one last form, that is Form H. This is form for maintenance of permanent record or applications for grant, rejection, or registration under the prenatal diagnostic technique. So these are so many like Form H till Form H. These are the forms. And this is taken from the appropriate authority handbook, because the government of India understood that there are various nefarious activities going on in the name of appropriate authority. So there is a detailed appropriate authority guidebook also, what the appropriate authority should do, how it should do, how it should report, how it should go to your place, how you should behave when they are visiting in your clinic, how the appropriate authority should prepare report. Everything is laid down in the operational or handbook for the appropriate authority. Government of India has ensured that it is there. One slide more. And as I said, like in 2003, the ultrasound was inserted in the PCPNDT Act, and like then after then, so many problems started. We saw those boxes. Next slide, please. Yeah, so this is the tabular form where I have just written or compiled, and it is basically not my work. I prepared the slide. It is from this article which I have given. All the references which I have taken, I have given the references. You can see major violations are basically these: sex selection, determination, and communication prohibited. And if there is any contravention, it is major violation. Any deficiency or inaccuracy in record keeping as per revised Form F. Again, if appropriate authority is finding any problems here. Okay, voice is very low. I don't know why. They will say that there is a major violation. Then a prohibition of advertisement relating to PCPNDT Act. So these three violations are major violations. So these three are strictly not to be done. Then there are minor violations. And problem is, if you do major or minor, both are punished. If we, Dr. James, sir, please go to the previous slide. I will just quickly go through the punishment. You can see both are punishable offenses. Both of violations, major or minor, both are punishable violations. And these both type of violations carry a sort of good or big punishment. You can see like under section 23, punishment up to 3 years plus fine up to 10,000 for first offense, and for second offense onwards 5 years plus fine up to 50,000 plus temporary suspension of registration number by the MCI. And now it is NMC. So they are very big violations and very big punishments as well. So you can see if the second violation is done, if you see the deficiency or inaccuracy in record keeping is noted by the appropriate authority, then the punishment is like under section 23(1) plus as above. So, and if you see last one, prohibition of advertisement related to PCPNDT Act, again there is punishment which is laid down, and it says under section 22 parenthesis 3, imprisonment up to 3 years plus fine of rupees 10,000. So these are grave major violations, and then there are minor violations also, and all those violations also bear punishment. You can see the minor violations have the table is having like 1, 2, 3, 4, 5, and then ABC. And you can see non-availability of the copy of the act at the center at a conspicuous place. Means you just see how important it is that copy of the act should be also there in the clinic. Because if you are not keeping it and the appropriate authority says that where is the copy, they are not finding it, they will fine you. They will say that we have noted a minor violation. And when there is a minor violation, what is the punishment? The case to be launched in the court of JMFC. Now just think, a simple thing like keeping the copy within your clinic premises, ready to be achieved or ready to be sold to anyone who is asking for it. If you are not having it, it is a minor violation and you might be punished. You might be having to, go to the court and all. Then there is non-display of registration certificate issued by the appropriate authority at the center. Again, it's a minor violation. First offense brings you 3 months prison with fine, which may be up to 1,000, or with both second offense. So these are minor violations, but these can again give you punishment. 3 number is non-display of board in the premises of the center in English and local language that declares that disclosure of the sex of the fetus is prohibited under law at a conspicuous place. It should be prominently visible to everyone who is coming at your clinic. So these are the minor violations. Again, there is minor deficiency in record keeping. Then complaints against the center. If there are complaints coming to appropriate authority or the state authority, it is again a minor violation, and it again will give punishment, and it can be in the form of sealing of the machine itself, confiscation of the whole premises sometimes of the machine, and fine, etc. Owner or employee not qualified, but they are doing ultrasonography. Again, it's a minor violation. Again, the machine can be seized, center can be sealed, anything can happen. Case can be filed. More ultrasound machine, less number of registrations. Again, it's a minor violation. Mobile ultrasounds, conducting ultrasonography at locations not registered. Again, it's a minor violation. And I think when we are talking about point of care ultrasound machines, this last minor violation is very big deterrent. So these are the violations, major and minor.
Rishabh sir, the time is up, sir. Can we wrap it up, sir?
Okay.
Yes.
Yeah, I mean, this is my last slide. These were the suggestions. I think as more panelists will come and more seniors will come, they will start deliberating on these. But the thing is that this act says that it should be having only one focus, that we want to curb the female feticide. But what is happening, like there are a number of corrupt practices being employed by everyone, from the service provider, from the appropriate authority, or from the authorities itself, which has led to more complex problems. And because the onus of the burden of proof lies on the doctor finds himself or herself in a perplexing position. So this is all about an overview of the PCPNDT Act. Thank you.
Thank you, sir, for that insightful talk on the overview of the PCPNDT Act and the implications and the violations, what penalties can it attract. Now I will hand over the podium to Bala, sir, for take over to you, sir.
Yeah, thank you, Dr. James, and thank you, Dr. Rishabh, for explaining to all the anesthesiologists about the PCPNDT Act and what it actually means. But next, we move on to a very important panel discussion to be led by the immediate past president of Indian Society of Anesthesiologists and the current academic chair. He was also the past president of Indian Society of Critical Care Medicine and initially worked as the head department of anesthesia in the prestigious Tata Memorial Hospital, Mumbai, currently working as the chief of intensive care unit at Leelavadi Hospital, Mumbai. And I request Professor Dr. J.B. Divatia sir to lead the panel discussion with eminent anesthesiologist. He would introduce each of the panel members and he will share the thoughts and the concerns of anesthesiologists. And as we all know that this tool, the ultrasound, has been used extensively in the bedside for point of care ultrasound and also to life-saving procedures, including starting IV access in a patient who is collapsed, starting arterial lines, and critical care unit, anesthesiologist in the intraoperative period and the emergency physician. So it's been very important to have this tool. So may I request Dr. Divatia to start his panel discussion by introducing the panelists and taking the discussion forward. Over to Dr. J.B. Divatia, sir.
Evening. Thank you, Dr. Balavenkat, and thank you, Kaho and Dr. Lalu Joseph for this important collaboration. Please forgive my appearance, but I'm stuck in Bombay traffic and I'm strapped up. So let me just, so I'll switch off my video, I'll go incognito. So this, we'll now have a small discussion on, some very important practical aspects. I hope you can all hear me, right?
Yes, sir, we can hear you.
Hello?
Yes, we can.
Yes,
Yeah.
sir.
Yes, sir.
So we've got some eminent panelists with us. So my first panelist is Dr. Srinivasulu. He's the professor and head of the department at WIMS Bellary. He's an eminent anesthesiologist, a member of the governing council, and he has done a lot of work on the PCPNDT Act as far as anesthesiology is concerned and interacting with various authorities in Karnataka state. Welcome, Dr. Srinivasulu. We also have Dr. Naveen Malhotra. He's the president-elect of the ISA. He was the past secretary of the Indian Society of Anesthesiologists. And Dr. Malhotra was a professor in the Department of Anesthesia at PGIMS Rohtak, both in the general anesthesia department, then in the cardiac anesthesia. So he's got extensive experience with ultrasound in these areas. And now he's a prominent American pain physician who, after retiring from Rohtak Medical College, he's now started his own pain center. And he will give a valuable perspective on the use of ultrasound and how he has coped with the PCPNDT Act in the practice of pain medicine. And last but not the least, we have Dr. Pratibha Kane from Pune, who is, apart from being an anesthesiologist, is a medical legal expert. And she will advise us on how not to get into trouble and what to do if we do get into trouble with not just the PCPNDT Act, but she does it for various sort of other things. So welcome, Dr. Kane and Dr. Malhotra.
Thank you, sir. Thank you.
Okay. So I'll just first, very quickly, I'll ask Dr. Srinivasulu and I'll ask Dr. Naveen Malhotra how ultrasound has affected their practice, how it has changed their practice, and what is the role of ultrasound in their current practice today. And very briefly, because you've got only 20 minutes. So first we'll talk about how important or whether it is important or not in their current anesthetic practice today. Dr. Srinivasan.
Good evening, sir. Sir, all of you will agree that use of ultrasonography and echocardiography has definitely lifted the level of care we are giving to the patients. We as anesthesiologists, clinical care physicians and pain therapists are involved in usage of ultrasound. And it will definitely a boon to the anesthesiologist to improve the patient care. That's it, sir.
Okay. Dr. Naveen, in your experience, what is the scope and role of ultrasound in your practice, or at least of pain medicine, as a specialist in pain management?
Thank you, sir, for inviting me here. I think no pain physician can do a practice without a fluoroscope and a UHG machine. They have become eyes of any pain medicine specialist because from top to toe, daily, day in and day out, we require a probe, whether it is an occipital nerve block, whether it is a stellate ganglion block, whether it is a block around the shoulder, the suprascapular nerve blocks, intra-articular injections, rotator cuff tears, tennis elbow, carpal tunnel syndrome, or patients with cancer pain, USG guided anterior approach to celiac plexus, superior hypogastric plexus block, or inguinal and testicular pain, ilioinguinal and iliogastric plexus block. Patients suffering from spasticity, the cerebral palsy patients, USG guided obturator nerve block. Then its extended role in the musculoskeletal conditions, caudal epidural, SI joint block, intra-articular injections of the knee joint, plantar fasciitis block, tender Achilles block, you name it and you have it. So we all know and understand that when you inject under vision, you are going at the right place, and at the same time, you are not injecting into the wrong structures. So a USG machine is an eye for a pain physicians along with the fluoroscope, and we cannot survive in the pain practice without having a USG machine in our pain clinic or pain center. We have used extensively USG machine, whether we were in the institutes, for the anesthesia, for the ICU, for the pain clinic. And now I'm a full-fledged into pain practice. So to be honest, we have got 2 machines now. Over to
Thank you, Dr. Naveen. Yeah. Thank you, Dr. Naveen. So I think we've seen in pain, we've seen in anesthesia. I can tell you my own experience in critical care. We've had to relearn. We have to, in fact, learn ultrasound all over again, because a point of care ultrasound has become absolutely vital in critical care and emergency medicine. We do ultrasound of the lung, which was unheard of some years ago. We do echocardiography. We do, we look at the venous this thing. It helps us in our procedures to put in invasive lines, central lines, arterial lines. And I think the practice of intensive care today is unthinkable without ultrasound, which was not the case 10 or 15 years ago. And people like us have had to actually learn ultrasound all over again. And of course, now we've got in regional anesthesia, we've got the doyen of regional anesthesia, Dr. Balavenkat here. The use of ultrasound has sort of exploded the scope of ultrasound in regional anesthesia. And you can, like they used to say in Star Trek, ultrasound helps you go where no man has gone before. So you can virtually hit any nerve or any group of nerves anywhere in the body. So I think Dr. Balavenkat and Dr. Bajwa will both agree with me that, I don't think we can really work without ultrasound, whether it's in anesthesia, whether it's in critical care, emergency medicine, or pain medicine. Yeah. So now that we've got so much scope and so much use, and therefore we are all using ultrasound, and all of us were terrified by the previous talk that So I'm just going to ask Dr. Srinivasalu, how did you procure your machine, and how do you in your practice? I'm not talking of your institutional practice, because in institution you're relatively safe, but when you go out in private practice, you go to different nursing homes. Dr. Srinivasalu, how do you procure your machine? How do you comply with all those Form A to Z that were described? And, how do you do that? I think that'll be a valuable tip to people who want to practice ultrasound, use ultrasound in their practice.
As it is mandated by the government of India, we need to register our name to get the authorization from the PCPNDT committee to use it in for particular procedure and in a particular facility. So there were a lot of information gaps and misconceptions amongst our community. How to get the registration, whether we will be eligible, all these things. So initially we had problem to register under this PCPNDT Act, but after going through all the rules and when we talked to our state chief of PCPNDT Act, so we again went back to our district PCPNDT and provided all the information and discussed with them all the clauses in the PCPNDT Act. Then they finally agreed that anesthesiologists, as they were trained in usage of ultrasound during our course, and it is there in the curriculum of our MD anesthesiology diploma or DNB anesthesiology. So we are eligible to be registered. So for this, initially, we have to apply to the appropriate authority. That is, in our place, it is the district PCPNDT committee. We have to apply through Form A. in duplicate, which asks for the our information about our medical registration, then our qualification, then the particulars about the ultrasound machine we are going to use, its make, model, and serial number. Then details about the
So Dr.
facility.
Srinivaslu,
Yeah.
where is this ultrasound machine? Is it your own machine or is it a machine which is placed in a nursing home or a hospital that you're going to?
Yeah, it's placed in a hospital, sir.
Okay. So it is a
But
hospital which
they
has to
have-
register the machine
Yeah.
and you have to register to use the machine.
Yes, that is required, sir. For this, the documents required are, one is the filled Form A, then our medical registration, then our degree. Our degree has to be entered in the medical registration, like MD anesthesiology or DNB anesthesiology or diploma in anesthesiology. That is what. Next, our ID, like Aadhaar card. Then the details or particulars about the ultrasound machine we are going to use, as already told, its make, model, and serial number. Then the facility where we are going to use this. That is the hospital details. Then an affidavit with an undertaking from the owner of the hospital that that particular consultant is going to use the ultrasound machine for the purpose of, like in our example, for regional anesthesia, for point of care ultrasound diagnosis, then also for uh, pain therapy and all that. So in that affidavit, we should also mention that we are not trained in prenatal diagnosis and we are not going to use that also. So these are the particulars which we have to provide it to the appropriate authority. Then usually within 30 to 60 days, they will respond. And if yes, sir.
So Dr. Srinivaslu, if I may ask, how painful or how smooth was this process in your Karnataka state? Is it a painful process or is it something you just fill the form and forget about it and you get a response?
Initially, there was a problem, sir. Initially, they said, no, how can we register anesthesiologist name in PCPNDT? That's what they told. Then even Dr. Balavenkat sir gave some inputs about this to me. So one of my friend was the PCPNDT chief in Karnataka. I came to know after some time about that. So I talked to him and I showed him all the things. No. Already we have started registering the anesthesiologist name for this purpose. And you also apply and will give appropriate instructions to all the district authorities. That's what they have told.
Okay, great. So thank you, Dr. Srinivaslu. Dr. Naveen, what has been your experience in registering your machine and your center and yourself and your other colleagues as users in your private clinic in Haryana?
I personally believe that we have to follow the rule of the land. So just if you can see, I'll share the journey which Dr. Srinivaslu was talking about. And when I switched over from, I just intentionally blurred some pictures. This was the PCPNDT license in the name of my wife, right? My request and suggestion to all of you will be, there is no harm in knowing the rule and following it in letter and spirit. Being the son of a lawyer, I personally have an affection towards the law, so I believe that we should follow it. Now, this was the letter which was written by my wife, that these three doctors, me and my two other colleagues, will be using the machine which is existing. Yes, you have to attach your MD degree, your registration, your Aadhaar card, self-attested, along with an affidavit. That which clearly says that the genetic clinical laboratory combination owned by me shall display a notice that we do not conduct any technique, test, procedure for detection of sex of fetus or for selection of sex before or after conception. We went further and wrote that we shall use ultrasound for nerve blocks in patients suffering from chronic pain. The use of ultrasound for performing nerve blocks is in the interest of patient care as it improves safety and efficacy of nerve blocks like suprascapular nerve blocks, stellate ganglion blocks, celiac plexus block, ilioinguinal iliophagistic nerve block, genicular nerve block, occipital nerve block, obturator nerve block, sciatic nerve block, piriformis syndrome, caudal epidural block, SI joint block, and etc. That these nerve blocks are in the curriculum of anesthesiology and are the domain of anesthesiologists. So we
Okay, great.
clarified each and everything. Then
So I,
Then they asked, you have to mention the timings also, whether you are doing it in the daytime or during the emergency also, which you have to clarify. Each and everything is signed and stamped by all the operators. Then this was the machine. License was initially chosen in the name of Dr. Akim Malhotra. The three pain physicians' name was also entered. Going further, we bought another machine and we sent this letter requesting for permission of purchase. Whenever you buy and suppose a new machine has to be bought, you request for permission of purchase. Along with that, you have to attach the supply order to the machine, to the firm, like we gave it to the Sonosite. The certificate of PCPNDT registration of that ultrasound firm, and this certificate should be uploaded on the portal of that particular government, like Haryana government PCPNDT portal. That ultrasound machine provider should be registered. They get a serial number for that. Along with, again, you attach your degree, certificates, and the stamp papers. The PCPNDT people then give a permission. Okay, you can go ahead with the purchase of the machine. And whenever the machine is installed, you have to give the information immediately. The machine comes to the place. You tell that, okay, now the machine has been installed at that particular time on this particular date, signed by all the operators. The installation report is attached, the invoice is attached, and the map where the machine is stationed. So, okay, the earlier machine was, if you can see, it was at one particular place, and now the second machine is in the OT. So we specify on the floor plan that where the machine is lying. And then they come for inspection, check the serial number of the machine and the serial number of the probes, which are as per the installation report. And then you get another PCPNDT in the name where the two machines are now written, Wipro GE as well as Fujifilm Sonosite. The validity of it remains the original date when the license was granted, which was 5 years. So next year, we will again go for renewal. Then you have to keep a record keeping. You have to have your own ultrasound registers, and a monthly report is sent where you write how many ultrasound you did it that particular month and the cumulative report of the year, whether you did it on any antenatal patient or not. Fortunately, 99.9% chronic pain blocks are contraindicated or relatively contraindicated in patients who are pregnant. So, but still we submit a monthly report, how many are done, and the register is signed by the particular operator who does that blocks. And along with this, all these affidavits and everything, they go. So what I'm trying to show by these pictures is that there is no harm in following the rule. The PCPNDT meeting occurs under the chairmanship of distant appellant and appropriate authority, the civil surgeon, a nominee from the deputy commissioner, a nominee from the legal fraternity. They all sit there once in a month. And ours was a very smooth process. We got it whenever we applied. To the extent that I wanted it in the previous financial year for income tax purposes, they gave the permission in the previous financial year also. But yes, you have to attach all the papers. You cannot say that the civil surgeon is my student, why is asking for papers? The PCPNDT people are my students whom I have taught in the MBBS, and now I'm the senior professor and head, I won't give the paper. You have to give the papers. Then, yes, as an anesthesiologist, they will give it smoothly. 10 years ago, there was some issues going on that whether anesthesiologist can have that UHG machine in their name or not. But I think that's a thing of past in majority of the states now, majority of the states, that anesthesiologists may have difficulty in procuring. I can personally say when I was secretary and now Dr. Bajwa and Dr. Balagankar, anybody having any problem, they approach us and we guide them how to go for a PCPNDT license. So these are my inputs as a private practitioners of buying a new machine or adding your name in the existing machine.
Yeah, thank you, Dr. Malhotra, for that. I think you highlighted very nicely that you should follow the rules. Follow the rules of whichever state you are in, and make sure your document is perfect. And there should not be any problem for any anesthesiologist to register for the purpose of doing ultrasound under the PCPNDT Act, buying an ultrasound machine. But please follow the rules. So I think we've heard from both these anesthesiologists, that it is definitely doable. You have to do the paperwork, but at the same time, it is something which helps you elevate your practice. So I think that's fantastic. Now I'll turn to Dr. Karne. Madam, so I'll ask you 2 or 3 quick questions. There are some private anesthesiologists who have a portable ultrasound machine and they go from place to place doing their blocks and doing their work. They may not necessarily document each and every block that they've given or procedure that they've done. What do you think of a practice like that?
Well, portable machines, as far as I know, they are illegal and they should not be used. The place has to be registered, and the ultrasound machine is not allowed. Mobile genetic clinics are also under a big scanner, and nobody should have because now even on your phone you can get an ultrasound machine pro, but it is illegal. That is as of now.
So message is very clear. Please don't do something like this, right?
Please do not do it.
Okay. Now
The
many
consequences
people
are very grave, and we get and people are doing this because the facility, I mean, the institution does not want to add your name or does not want to get that license, but do not then give this, service in those places.
So now many people argue, the documentation is very laborious and taxing. And they're saying, I'm doing my procedures in males. I'm doing my procedures in children who are below 5 years of age. I'm doing my procedures on menopausal women. Should I keep a document each and every of these procedures, even in people who are obviously not pregnant or ever going to be pregnant?
No, sir. No. Our own documents are enough. And actually, let me just clarify for everybody that anesthesiologists are not legally trained to do any obstetric ultrasound. Okay. So all you have to do is give a declaration that we do not do obstetric ultrasounds. We are not trained in it. So that is a personal declaration that you have to make when you get registered to the PCPNDT authority. That is very, very clear. Now, where do anesthetists get into crossfire, crosshair with the law is now we have said preconception and post-conception, sex selection. Now, many procedures which may be illegal, okay, either pre-conception or abortions and cesarean sections after sex selection, you need an anesthetist. Okay, so I just wanted to just highlight one case which has happened at least 15 years ago, and it was that a female fetus was found under a bridge. They did some investigation and they found that it was, I think, a 28-weeker female child, and it was done by cesarean section. They arrested the obstetrician and the anesthetist. The anesthetist was a young girl. She had a 5-month-old baby. And we were all really, really shocked that why is the anesthetist being made responsible for some illegal acts of the surgeon? So in her defense, she said that I did not know that this was an illegal cesarean section. I was called for an emergency cesarean section. I went there at 12 midnight and I gave spinal and the baby was born. I mean, the judgment you must hear, because what the judge said, that if you wanted to save this baby, you would have called for a pediatrician. The baby's fate was already sealed. There was no pediatrician who was in the theater to manage a fetal distress. That itself, he says, is evidence that you never wanted to save this baby. And let me tell you, they have written in the judgment that anesthesiologists are co-conspirators. They did not accept that we don't know what illegal things the surgeons are doing. They have very clearly said that without the help of anesthetists, illegal abortions or illegal, IVF, illegal ARTs cannot be done. So it puts a very big responsibility on the anesthetist to know what their surgeon is doing.
So this is actually going way beyond doing just the ultrasound. It is, but of course, this is covered under the
Because once
ambit
the
of the
ultrasound is
PCPNDT Act.
done, Dr. Divatia,
Yeah.
once the sex is selected, the next thing is an abortion.
Yeah, so I think that's a very important point you made, that even though this is not related to ultrasound per se, it comes under the ambit of the PCPNDT Act, and we will be sort of willy-nilly, without knowing, will be caught somewhere in this trap, So without having touched an
It is sex
ultrasound machine.
selection, and after sex selection, there is an action, and in that the anesthetist has to participate.
Yeah, so I think all of us need to take note of this fact as well. But that happens, in many other situations, on unqualified doctors doing surgery and all those sort of things. That's a different matter altogether. But now,
In
suppose.
this, she did not get bail. And it was, I mean, we were all really, really upset at that time. But then when the judgment came out and they said, why didn't she resuscitate the baby? So, it is so, I mean, I thought the judge was absolutely amazing to just say that this is the evidence that you all actually planned to not save the baby.
So, okay, now so that was coming to the next question. Suppose we get some sort of notice under the PCPNDT Act that, you have done an ultrasound procedure and your records were not in order. Your register was not well maintained. How do you respond to such a notice and that sort of thing? Are
Well, I
anesthesiologists
told
liable?
you that we
are not.
I mean, sorry, we are not maintaining a register for all the blocks. Our documentation itself is the register when we write USG guided block. And like I said, that we personally have given a declaration. Then in the OT, there is that signage which says that we don't do any sex determination and we do not inform the patients. Okay. So this is our personal thing. We do not make a separate register, and all our names. In fact, if we leave the institution, we are supposed to delete that name, and wherever you join, you have to go and register again from that institution. So we are not keeping F forms. We are not, we are not expected to do that. But yeah, for smaller places, actually it's the vigilance of the appropriate authority. How how much they want to prove. They will go into the details. But as far as anesthetist goes, it is illegal for anesthetists to do obstetric ultrasounds. So do not ever do them. And we do not keep any separate register for ultrasound.
So you don't have a register for your blocks and
No,
procedures or your
no,
screening
no,
echoes and all those that you do? You don't do at all.
no, no, no.
Okay, and that is not required under the PCPNDT
It
Act
is
once
not
you've made an
required because
affidavit.
we are not doing obstetric ultrasounds.
Okay.
The PCPNDT is mostly for obstetric ultrasounds. That you have to send it, you have to in 5 days you have to send it, monthly you have to upload it.
Okay. So, but Dr. Naveen was mentioning that he still maintains a
No, but
register
it is
for
a
his.
good. See, there is nothing wrong in maintaining the register.
Okay, but it is
Absolutely
not.
nothing wrong. But it is not mandatory, not for anesthetists, and it is not
So,
for our. We are not doing obstetric ultrasound.
so Dr. Naveen, you can quickly respond. And there's a
Yeah.
message from Dr. Saurabh Barde saying that in Nagpur they need to maintain a register for blocks and procedures.
Sir,
Dr. Naveen?
why we are maintaining register is that yes, these are the procedures anyhow we are going to maintain an OT register. We are doing a procedure, the
That's
record OT, and now we have a separate USG guided OT register or a procedure register where we write, okay, this is the male, female, whatever it is, and this was the block given.
Okay.
It has,
But
but
if
sir,
you don't, but if Naveen had not been doing it, he would not have been liable under the PCPNDT Act. Is that right,
No,
Dr. Kani?
no, sir,
Yes.
but I think there is no harm in maintaining the register because until
That's what I
unless you have
said.
the
There is no
record,
harm, but we are not
until
doing
unless
it.
you have the
There's no
record, what will we show during the inspection? And in our state, we have to tell the total number of ultrasounds done. Non-pregnant patients, 60 ultrasounds. Pregnant patients, 0 ultrasound. Our report goes like that. So we are sending it every
So there's
monthly.
nothing wrong in maintaining. In fact, it is a good thing. But the
secondly,
main PCP, see, you want to, kind of take it in the letter, it's absolutely fantastic. But in the spirit, it is really not required.
and secondly, sir, even in the institute also, I just like to highlight which Madam was highlighting. I switched from Department of Anesthesia to Cardiac Anesthesia. I got my name removed from the Department of Anesthesia PCPNDT license. Got my name added in the Cardiac Anesthesia equity machine. When I took a VRS, I got my name deleted from that and got it added here. So it is our responsibility to ensure to write a letter to the district appropriate authority, come civil surgeon. Okay, now I am not in that institute. Please delete my name. That's it.
That's it. Yes.
Okay, so I think it's a good practice to maintain a record and have it ready to show to the authorities, because in Maharashtra and maybe Haryana,
They are quite
whimsical.
vigilant.
Yeah, if they want to trouble you, they can, and they'll give you a handle to twist your arm. So I think it's always good to maintain a record like Dr. Naveen has been maintaining in his practice, right? So if we get a notice, Dr. Kani, quickly, because I think we run out of time, how should we respond? I mean, this is not like a police case or what sort of a case will they file? Is it a criminal offense? It's non-bailable. It's a criminal
It is
non-bailable. So how do you deal with it?
non-compoundable.
You've given a block, you've gone home, and then the cops come up and say that you've not registered, you've not done this, you've not done that. How do we respond?
No, but see, registration, not being registered is a major offense. So you will have to go, respond. It is a non-bailable offense. So you can't, use the ultrasound unless you are registered, your machine is registered, your place is registered. So why
Dr.
do you
Kadi,
want to take this kind of a
a
chance?
blunt question, you don't have to reveal names or this thing. Have you ever come across any instance of any anesthesiologist who has been caught or prosecuted or whatever for not being registered and using ultrasound? In your knowledge, has that ever happened to any anesthesiologist?
No,
No.
no. Because
No.
like all our panelists have said, that it is new. They yet don't know that they can prosecute anesthetists.
So the more we use and the more we register, the more we are likely to become targets.
Yes, So
As of
so
now, they are
far,
not a
they are
target.
not going after. See, because we are a very small fry. We are not like an obstetrician who they have caught. They would be more after that. There's a lot of procedure to be followed to prosecute. Also, you have to be very certain that your notice has come from the appropriate authority, because sometimes the police take some suo motu action. Those in the High Court are being, kind of actually squashed. If it does not come, there are specific rules of how to prosecute. If it is a private complaint, then you have to give 15-day notice to the appropriate authority that you're going to bring in a complaint. So the appropriate authority is the authority who can send you a thing. Just a police person coming is not likely.
Okay, so I think we've exceeded our time. So thank you all very much, all the panelists. I think a few messages come out very clearly. One is we are recognized to register as specialists under as qualified to use ultrasound, and many of us have done it. Uh, we also please make sure that you follow each and every rule. The procedures may be slightly different in the various states, but please make sure you follow the rules to the T, right?
Dr.
And
Dibatia, there is some question about cardiologists being allowed to carry their their ultrasound. They are not allowed. The other thing is that the Ophthalmologist Society, this is important for the white paper that we are making, that the Ophthalmologist Society in 2018 have brought in a case, and the Delhi High Court has stayed that, the scan A, scan B, and their machines coming under PCPNDT Act.
yeah,
So we can, actually look at those cases.
yeah. So I think that's another. But I think the bottom line is please follow the rules, please follow the law, and
Yes, for the time
and
being, yes.
and documentation is extremely important, whether it's mandatory or not. It's always a good practice to document.
Yeah.
And lastly, I think the last point you made is I think all the non-gynec associations who are using ultrasound, like us, like the
You can
ISA,
make those petitions,
like
yes.
the opthal, the cardiology, they can all, if they
Cardiologists.
get together and make a sort of joint petition or a joint movement, something needs to be done. I
Yes,
agree.
no,
This is a
and
social.
it's already started. See, the
This is yeah.
2018, it
So
is already started, so we can build on that.
yeah. So there is a socio-cultural problem, but it should
Yeah.
not at the same time serve as an impediment to the progress of medical
Because the
practice.
cardiologist said we can't work without a echocardiogram.
So I think maybe
So
CAHO and ISA and other organizations can take this forward. Of course, we have to
yes,
keep the socio-cultural context in mind, but at the same time,
yes,
and we also need to behave responsibly, follow the
that's
rules
right.
as they are today, and hopefully they will change for the better tomorrow for us. Yeah, so thank you very much for all your views and comments
Thank you, doctor.
and sharing your experience. Over to the.
Thank you, sir. Thank you very much to all the panelists for your insightful discussions. I think most of the queries in the chat box have been answered during the discussion. So we are grateful for that. Now we will move on to the next session. And myself, Dr. Ranjit Emmanuel James, and along with me, Balasar, the president of ISA National, will be there to moderate this panel discussion. For this panel discussion, I would like to invite the following panelists. The panel discussion is going to be on the way forward, which will kind of build upon what the previous panel discussions had deliberated. So our first panelist, we are delighted to introduce Dr. Vijay Agarwal, a distinguished pediatrician and a healthcare leader, graduated from Maulana Azad Medical College, New Delhi. He currently serves as the president of CAHO and has held pivotal roles such as co-chair of Accreditation Committee of NABH, Director of Operations and Administration at Max Healthcare, Executive Director of Pushpanjali Crossley Hospital, Ghaziabad. He also advised Max Healthcare on quality and business excellence. A key contributor to public health, Dr. Agarwal was a lead member of the Immunization Advisory Committee of the Indian Academy of Pediatrics, advocating the pulse polio strategy alongside Dr. Harshvardhan, former Health Minister of Delhi. He founded the Nursing Home Forum of the Delhi Medical Association, established centralized biomedical waste management facilities, and served on the Government of Karnataka Committee for Procedural Costing with IIM Bangalore and NABH and other stakeholders. As the chair of the Technical Committee on Public Policy in Healthcare, he continues to shape healthcare standards. Dr. Agarwal has been honored with the Distinguished Alumnus Award from MAMC, the Lifetime Achievement Award from IMA, and the Quimpro Platinum Award for Healthcare in 2019. We welcome you, sir. Moving on, our second panelist, we are privileged to introduce Professor Dr. Rajkumar Mani, an eminent pulmonologist and critical care specialist, currently serving as a Director of Clinical Services and Chairman of Pulmonology and Critical Care at Yashoda Hospital, Kaushambi, Ghaziabad, Uttar Pradesh, a past President of the Indian Society of Critical Care Medicine. He served as the Chief Editor of Indian Journal of Critical Care Medicine from 2012 to 2018. Dr. Mani was the lead author of the ISCM's seminal position statement in 2005 on end-of-life care, which influenced the Law Commission of India's 196th report on treatment limitation for the terminally ill. As chairman of the End-of-Life Care India Task Force, he advanced capacity building and legal policy for end-of-life care, contributing to 2 ICMR publications on defining the terms for end-of-life care as well as DNAR guidelines. Representing Indian Society of Critical Care Medicine, he pleaded in the Supreme Court case in the infamous case of Common Cause versus Union of India, 2018, which recognized the right to execute a living will and refuse life support. And he was the appellant in the modification judgment in 2023, which was again laid down by the Apex Court, which simplifies the procedure for withdrawal and withholding of life support in terminal illness. He led the Ministry of Health and Family Welfare's Technical Resource Group to develop national guidelines for ICU admission, discharge, and life-sustaining treatment withdrawal, which was published in December 2023. Dr. Mani has authored over 100 articles, 24 book chapters, and several op-eds in leading newspapers to his name. We are glad to welcome you, sir. Our third panelist for the session, we are happy to introduce Dr. Rajiv Joshi, a consultant pediatrician, a geneticist, and health informatics expert with a remarkable blend of medical and legal expertise. He trained at Duncan Guthrie Institute of Medical Genetics, UK in 1991 and completed a fellowship in biomedical informatics at the US Department of Health's MBL in 2008. He holds an LLB degree from Savitrabai Phule, Pune University. Dr. Joshi is a trailblazer in medico-legal advocacy, bringing practical insights to public health policy through his extensive litigation experience. As a founder member of the Medico-Legal Society of India, he has conducted several legal awareness and medico-legal protection sessions. His impactful legal interventions include filing a criminal public interest litigation in the Bombay High Court, leading to the Maharashtra government's agreement to repeal outdated legislation on violence and enact a new act to protect the healthcare services. He also filed an interlocutory application in the Kerala High Court case, contributing to strengthening of the Kerala Healthcare Act in 2023, now among India's most robust one. Additionally, Dr. Joshi has filed intervention applications in multiple Supreme Court and Bombay High Court cases addressing critical issues such as patient deaths, generic medicine policies, and healthcare regulations. With his unique combination of medical expertise and legal acumen and hands-on experience in high-stakes litigation, Dr. Joshi offers invaluable practical perspectives to today's panel discussion on the PCPNDT Act. And our final panelist for today's discussion, Dr. Rishabh Kumar Rana, who has delivered the previous session on overview of PCPNDT Act. Now, moving on. Vijay sir, I would like to direct the first question to you, sir. Sir, having heard about some comments in the chat box about how can we get certified, or how can we get the privileges to certified to use the ultrasound machines for non-obstetric settings? I would like to place this question in front of you. How can organizations like CAHO collaborate with professional societies like the Indian Society of Anesthesiology and the state health departments to create a standardized approval process for ultrasound equipment used in non-obstetric settings?
Thank you. Thank you, Dr. James. I think Dr. Tewatia, in his concluding remarks, had more or less tried to answer this question as to what we need to do. The important thing to my mind is, first of all, to start educating everybody about the use of the non-obstetric uses of the ultrasound, which are now today, I mean, it is going into emergency medicine, critical care, cardiology, nephrology, urology, anesthesiology, and whatnot. So, and the point of care use of the ultrasound machines, how important it is. So, first is also to keep on educating, I would say, the policymakers, our politicians, public need to understand about the uses of this particular technology or the particular this thing. And therefore, notwithstanding, we do not want to kind of violate the basic intent of the PCPNDT Act, and which is regarding the sex determination and all that. But I mean, the act has been there since 1994, I think, and since then has always had, one has to see, in fact, that how can you fulfill that particular aim as well as try to liberate the use of the ultrasound in the other areas. And therefore, these organizations, these societies, I think, need to collect all the kind of evidence in terms of how can you try to give confidence to the lawmakers that without trying to misuse the machine, how can we fulfill that? So I think all the angles which have already been kind of spoken about, and more, and in today's date, with the technology becoming kind of available, I think we need to kind of produce a kind of, first of all, an internal white paper needs to be produced. We need to bring in, I think, more associations also together. Various other professional bodies need to be kind of brought in together for this particular purpose. I'm sure that they would like to, even IMA, I think, needs to kind of come into picture. And therefore, there is a case for us to start, I think, educating as well as thinking about the legal remedies. Like, for example, I heard that the Ophthalmology Society has already done something. We can think as to what more can be done.
Yes, sir. Thank you, sir. Mani, sir, as we have heard from the previous panelist as well as Vijay sir about the various uses of, the point of care ultrasound, which is being more used rampantly in the modern medicine. Sir, how can we streamline the use of this point of care ultrasound for critical care specialists under the PCPNDT Act? And what role do you think the regulatory bodies or professional societies should play?
I think, as Dr. Vijay said, we have to liberate the use of the machine in context other than obstetrical. It's got nothing to do with PCPNDT to govern critical care use of ultrasound, okay, or emergency use of ultrasound. You can't be, regulating that, because it is the way modern medicine has progressed. Without point of care ultrasound, there is no modern. Critical care will be very much behind times. So I think urgently there is a case for review by the regulatory authorities, review by the lawmakers, that the ambit of PCPNDT should be confined to obstetrics, not elsewhere. It doesn't make any sense. And even in obstetrics, it is not realized the objective of reducing the ratio of improving the female to male ratio. In fact, it is getting worse. We just heard that in some districts of Haryana, it is 700 now to 1,000 male children. So it has not reached the objective because we are not regulating the other end, where the parents are doing the feticide. We are not regulating the feticide itself. We are only regulating the providers of ultrasound. And then strictly applying that to all ultrasound use is very damaging to the profession, in fact, to the growth of the profession. So I think this case has to be made very strongly by the profession. As Dr. Vijay said, various professional bodies and IMA must make a strong case and may say it boldly. It is not going to in any way deter the principles contained in the PCPNDT Act, okay, of saving the female child. But we can't throw the baby with the bathwater in this concept of saving the female child. You're preventing saving of lives by application of modern technology in the saving of lives as in critical care, emergency, and various other areas. So I would say we must start with educating the regulatory bodies that they must come up to date. I mean, it is 1994 and revised 2003, to include the preconception. But then it has not come up to date with the developments in medical science itself. No other part of the world is constrained by this sort of regulation of ultrasound use for non-obstetrical areas. So this has to be brought out and spoken very directly and boldly to the regulatory authority.
Yes, sir. Thank you, sir. As you rightly said, I think the first step is to educate the stakeholders about the non-obstetric use of the ultrasound, so that the undue pressure to regulate the one side of it, but not looking into the other side of the coin, which could ultimately affect the ratio of genders. Yeah. Sir, Rajiv Joshi, sir, I would like to ask you one direct legal question, in the sense, what practical legal recourse can we take at the district or state or at the national level to challenge issues under the PCPNDT Act? Because we have seen that a lot of challenges faced by different districts and different states, across the country. And how can we build a case to advocate for exemptions? Because as of now, we don't have any clear exceptions under the PCPNDT Act, and the scope is kind of, very narrow or restricted view. So how can we build a case to advocate for exemptions?
Can you please let me share my slide, please?
Yes, sir, you can share, sir.
So I just would like to start with saying that, yes, there is need of bringing all the specialties together. And I'm sure only anesthetists can do that, because anesthetists are interacting with all specialties and super specialties day in and day out. So instead of waiting for IME to take lead, I think it is anesthetists who can bring all together, because anesthetists are getting affected because their services in intensive care as well as in OT are getting affected unnecessarily because of these rules and regulations. So what I would like to say is that there are certain issues which can be handled by some changes in technology. For example, there can be geotagging of the machines in OT, ICU. So these are the places where the machines are used, right? OT, ICU, urology, ophthalmology, cardiology, OB/GYN, radiology. And then there should be a detection of probe that is being used with the machine. That suppose a machine in theater is used with the probe of ophthalmology, it should be detected. Similarly, a machine in the ophthalm OPD is used with a probe for obstetric ultrasound, that also should be detected. That technological possibility should be there. Then there should be a detection of imaging directly using artificial intelligence for what type of blocks are given, CVP lines are taken, lithotripsy, B-scan, color Doppler, OB/GYN, abdominal pelvic sonography. So it is easy for technology to do these things directly using the image analysis. I have been working with image analysis and it is not very difficult. Now, third thing is mobility of ultrasound machine from city A to village B. It is being done today to rampantly doing the sex selection and sex determination. That can be possible using technology. Now, next thing I would like to say, and this will be a little bit shocking, that there should be graded penalties for different crimes, and the radiologists and obstetrics people who are doing day-to-day sonographies regarding the fetus, they are getting penalized, say 3 years imprisonment. But if you use the cardiology machine for sex determination, the penalty should be higher. If you use B-scan ophthalmology sonography machine for sex determination, the penalty should be higher. If the urology machine is being used, the penalty should be higher. If the ICU machine is being used for sex selection, it should be much higher. And in OT, if the patient is brought into the OT and sex selection is done, then it should be the highest possible penalty, because that is a totally intended crime. Similarly, there has to be, like Dr. Rajmani said, there has to be penalty to the patient party. So the patient, husband, mother-in-law, father-in-law, mother, father, siblings, all these are responsible for the sex selection much more than the doctor, because Dr. A refuses, they will go to Dr. B, they will go to Dr. C, they will go to Dr. D. So they are also should be punished. And now I would come to this figure of 919 per thousand women to men in 2020 to 929 per thousand in 2025. So only 1%, that is marginal benefit, is seen by this PCPNDT Act. So this figure should be put forward to the government. And then we have to actually do the understanding of the root causes, promote value of girl child, strengthening legal reforms, monitoring PCPNDT Act, healthcare system reforms, education of the people, shift in burden of proof, strictest penalties for misuse. And now you use the technology for online registration process, then data analytics and trend analysis, automated alerts for misuse, mandatory software resources, then differential registrations, individual accountability and institutional accountability. All these things should be done using technology. And to end, I would just describe challenges that are going to be there in what I am proposing. A challenge is a retrofitting, challenge of data storage, digital information ecosystem, Digital Personal Data Protection Act, network bandwidth and expenditure. However, with proper and good legislation which can encompass all these things, I'm sure we will be able to do much better with respect to the female feticide also, as well as allowing the technocrats, doctors, anesthetists to use the technology. That's what I want to say. Thank you so much.
Thank you, sir. That was that statistics was really helpful. That at least in the last 5 years, around 1% of improvement is there with strict enactment of this law. Probably that statistics will help us to put the case forward that probably it's not this side of the coin which is creating the problems. We need to look into deeper and then try to root cause analysis to be done so that we can find out where the problem lies actually. Now, Rishabh sir, I would like to direct a first question to you, which is like, because we have seen the previous panelists, a few of one of them from Haryana and other person was from Karnataka and madam was from Pune. So, and from the chat box also somebody said in Nagpur the requirement is a little different from what is there in Haryana or Karnataka. So how can we address the inconsistent enforcement of Act across India to ensure that the clinicians, particularly in critical care areas, have equitable access to point of care ultrasound technology without compromising the Act's objectives, sir?
Thank you, Dr. James. I think number one thing is capacity building. Like what we have seen is when the CMO is asking for the busy clinicians to come up in their offices for updating on the PCPNDT Act, we see very few attendance. So it is another thing that the CMO is asking. Nowadays, we have got enough internet resources. Anyone can go to the Ministry of Health and Family Welfare website. They can look for PCPNDT Act. They can look for the appropriate authority guidebooks also, which I was saying earlier. So capacity building is the most important thing. In fact, what I'm saying is also backed by the evidence. Whatever researches have been done across the country in last few years, they have pointed out that capacity build means the information about the details of the PCPNDT Act is not as it should be even among the people who are either in the government hospital or running their own clinic. Until unless we bridge that huge gap of capacity regarding the PCPNDT Act, uniformity we can't expect, because Act is there, it is written, and it has undergone amendments. Even after 2003, there was an amendment in 2020 which said that, okay, after 6 months of ultrasound course, any doctor or any RMP, in fact, can practice this thing, and he can give his registration number, his name as the person who is going to do the ultrasonography. So amendments have been done even after 2003, but if the capacity is not there among all the people who are doing it, all the major stakeholders, we can't expect uniformity. That is one point I can suggest and I can quickly think of.
Thank you, sir.
Social awareness is the second thing. After capacity building of the person who are involved, then you create an awareness among the patients. We talk, advocacy should be there and so on. But first and foremost is every doctor must be well versed who is doing any sort of ultrasound activity about the PCPNDT Act. And also, don't panic about the appropriate authority. As Pratibha ma'am was very clear that it is not that anybody can come to your clinic and rate. It is only the appropriate authority who can come, who can place any sort of decision regarding the major violation, minor violation, etc., etc. So it is after you read yourself that you will be well versed with all these things. If you stay away from that, if you stay away from the appropriate authority handbook, how they have to be conducted, how they are to conduct when they are visiting your site, you will be always, thinking that, okay, what is happening? I don't know.
Yes, sir. Thank you, sir. Vijay, sir, I would like to ask you second question. Sir, what is the role of technology in reducing bureaucratic hurdles, such as, because we have heard from several practitioners that, when the ultrasound machines are being bought and then when it is registered, for them to come and inspect and then approve it, it takes, it's a laborious process for, to go through, and then the machines which are bought with what many lakhs are, lying idle. So how can we, kind of ensure that such a lengthy registration process is cut down under this act, while leveraging legal advocacy to ensure faster approvals without compromising the act's intent?
Yeah, I think there is a great scope to have this. I think because the problem, let us understand, the problem is a manual and the state-specific processes for ultrasound machine registration, and which are tedious, non-standardized, and time-consuming. That's the problem, and I think the solution is definitely to develop a centralized online portal for the PCPNDT registration and renewals with automated document checks and tracking. So enable the real-time application status, digital signatures, and automated alerts for renewals. And the impact would be a faster processing, reduced human interface, and minimized corruption and delays. So there is I think, huge scope as far as this part is concerned, definitely. But the authorities have to think about developing a centralized online portal. Second part also is the real-time usage of monitoring and the audit trails, which I think Dr. Joshi has also already kind of covered quite a bit, that you can today integrate and you can have a scan logging software in the ultrasound machine with a built-in geotagging, time spent stamping, and scan categorization, whether it is obstetric or non-obstetric. So use cloud-based storage, all the digital F-form submissions, patient consent, everything can now be digitized and can be online. And the impact will be, there will be transparent audit trails for authorities, reducing the need for arbitrary inspections and manual verifications. And, I think overall technology, and a lot of people are now saying that instead of the sex determination becoming that you do this, in fact, all children, we should know the sex, and therefore you follow the ones which are the girl child, follow them up and see that if, those children are not surviving. So we should have, in fact, let's think of technology in a much more positive and inclusive way, both to help the sex determination thing and also to see that how do we help out all the kind of harassment and the unnecessary kind of delays through the various procedures. And that's not only for this. I think a lot of areas of our healthcare regulations need to undergo that kind of a thought process.
Excellent, Dr. Vijay Agarwal said. Sir, how do we now make this happen? Like having understood all these issues, how do we make this happen, and how do we present this to the government agencies? What is the path we need to take?
Yes, so I think, for example, organizing a program like this, what you have done is just like a beginning. It is to kind of make all the opinion makers, first of all, because you see, unfortunately, the I will say the digital literacy of the healthcare leaders itself is so fragmented. They have no idea as to what level in our personal usage we are using, various things in a much more robust way. But when it comes to healthcare, we are laggards. So I think important thing is to showcase that how can technology help empower the issue of sex determination as well as liberate it. I think towards that, let us take some of the IT technologists also together with it, etc. We need to do a kind of a lobbying, I will say, with the regulators, with our politicians. I think even public, some of the voices from the public may also have to be reached, because ultimately non-usage of the ultrasound on the bedside is causing harm to them. And therefore, we have to also see that what kind of, I will say, patient safety issues are coming up because of the limited availability of this particular modality. So it's going to be a journey, sir. There is no easy solution, but I think let's make a beginning.
Thank you, sir.
Thank you, sir, for your insightful thoughts. Now, Mani, sir, I would like to draw your attention. Sir, yes, sir, Rishabh, sir, you want to say something, sir?
Yeah, sorry to interrupt, but I was thinking that because the MTP Act, sorry, so PCNPNDT Act, Chapter 2, Section 3B, it says that no person shall sell any ultrasound machine or imaging machine or scanner or any other equipment capable of detecting sex of the fetus. So if we can leverage this and ask the technology or the industry that kindly give us a machine which clearly says that it is not going to determine any sort of sex. So if for people who are in cardiology, who are in ophthalmology, if the companies who are manufacturing ultrasound machine, if they can be pitched that such machine can be used, and I think if the people are using that type of machine, that type of ultrasound, which the company makers are clearly saying that they're certifying that this cannot anyhow determine the sex of any fetus. So if that type of machine can be purchased from the
Is there any such type of machine, sir, whether you cannot do it? That is the issue. Even today, a cell phone is now going to be there which can determine it. And therefore, I'm saying that it is all right for them to write that. But the problem is that therefore, no manufacturer is going to be right that this is not capable of doing this. So it is dependent on the operator eventually.
Yeah, the intention of the operator is very important. Dr. Bala Venkat, actually in the Act, there is one section 31. And that section 31, it gives the power to exempt, it allows the central government to exempt certain educational or research institutions from some provisions under specific conditions. So we can leverage this section and say that we need these exemptions. Of course, there will be some procedure, but we can, because there is a provision to so we can argue on that.
Sure, madam. Yes, madam.
Yes, madam. Thank you, madam. Thank you for bringing this up important point. Mani sir, I would like to quickly ask you. So you have demonstrated that you have fighted for the end of life care policy reforms in India for almost over 2 decades. So I would like to ask you, can you draw parallels from what is your experience in bringing a change in end of life care policy in India especially in the gray area, like, point of care ultrasound usage in clinical practice, and to strike a balance with legal compliance, be it formulating a national guidelines or bringing up legislative amendments or bringing up, executive directions based on the powers vested with the appropriate authority, as Pratibha Kane ma'am said, that what should be our action plan, sir?
You see, to bring about a balance between the issue of sex determination and medicine at large, its use at large, we are artificially constraining the use of ultrasound. And this is staggering.
Then,
process.
hospital uses a digital system that complies with the DICOM standards for digital imaging. What is
Meenakshi,
DICOM?
Meenakshi, please
Digital imaging
mute
and
yourself.
communications in medicine.
Meenakshi, please mute yourself.
Handling.
Yeah, sorry, sir. Please go ahead.
Okay, sudden interruption. So what has happened is there is a huge constraint, underutilization, as Dr. Vijay Agarwal said, in the critically ill processes, and also in, of course, many chronic processes like chronic pain and all that. So we can. This is not sustainable. Continuing this way is no longer sustainable. It was okay in 1994, where the use of ultrasound was limited and mostly used in obstetrics. Now it is manifold use, and you can't constrain it. It will be only to the detriment of development of medicine itself and to the care delivery for the patient. So this should be made amply clear and without mincing words. We are law-abiding citizens, but then if the law hasn't evolved with medicine, then law itself becomes a tyranny. And we should, as good citizens, we should not allow that to go on. We must raise the voice, saying that it is inapplicable to outside of obstetrics. You can retain certain elements of the rules, like having, not portability. Okay, you can't put it in hands, portable, and identifying the location. Now, these are okay, but then we should allow a spectrum of physicians to use it. The exemptions must be expanded. I mean, immensely expanded. It can't be confined only to anesthetists. It has got to be intensive care specialists. It's got to be pulmonologists. It's got to be anybody who has indication for ultrasound. And that is manifold. In ophthalmology, in neurology. Now, the issue is the exemption list must be expanded urgently, and then the punishment should only be confined to the illegal obstetric sex determination. Nothing else. Nothing else is illegal. So why bring the entire process under PCPNDT Act? It should be confined to obstetrics. There should be some ideas generated, as now, that we should either limit the sale of ultrasound probes that used in sex determination. That can be done. That can be regulated. All right, not the entire thing. Just the sale of the probe should be only with people licensed to use for obstetrics. So I think time has come to raise a voice, a collective voice, to modernize this act, release it from constraining departments other than obstetrics and situation other than PCPNDT. This is all I can say. How we do it. I mean, that will be a battle parallel to the end of life care policies.
Excellent
Still
insights.
approaching every state health minister and our central health minister as a target person, at least. Maybe in certain states a doctor may be a health minister. Can we think of at least trying to reach such a person? Because ultimately health is a state subject. Maybe at least we can try to inspire some of maybe in Tamil Nadu or somewhere where they would like to go do something against the center.
Kerala is also very good for
we should be very happy to inspire them. Go ahead and do it.
Yes, sir. I think, Vijay sir, as you said, I think, if I'm not wrong, when Mani sir started this end of life care, I think before the Law Commission's report started, I think he and his team has invited the Union Minister for their program, and then they made him aware that what are the implications of this end of life care. That's how the journey started, and 20 years later, they ended up, creating the history in India, setting up the standard. So thank you, Mani sir, for your insights. Now, final question for you, Rishabh sir. What practical amendments can be proposed to the PCPND Act, though some few fragments have been discussed here and there? And how can such amendments be framed to gain acceptance from both and medical and legal stakeholders? Because oftentimes when we try to propose something, the other side of the stakeholders might have their objections point of uh, uh, concerns rising up, and then say that this may not work and it's for the better good, we would like to stick to what is there and all those things. So being an state implementing and monitoring committee person, what would you recommend, sir? What kind of amendments can be framed which could be practically be both acceptable to both the medical fraternity as well as the stakeholders in the legal or legislative side?
Yeah, thanks, James, sir, for raising those questions. I think in Jharkhand we have seen like well now the clinics are required to update on the online system as well. So documents, we're not saying that we will exempt it, but at least you upload it. You can keep the records later on, but at least upload on the website. So similar systems of upload website upgradation, website maintenance, and I think Dr. Joshi sir in his slides was very clear how geotagging can be done, updates on a website can be done, how different sort of penalties, penal sections can be there for different grades of violations. Apart from this, I think the Radiology Society, the Anesthesia Society all should come together and formulate a guideline about the usage of correct usage of point of care ultrasound machine. Because if you ask, I think as per the recent evidences which I have gone through on the PubMed, I am not seeing any evidence which is saying that every anesthetist or every uh, people or every doctor who was being interviewed about the correct usage of point of care ultrasound is well versed about it. One of the biggest barrier which they have highlighted or studies have highlighted is low training about the point of care ultrasound machine. So I think a guideline must be released by maybe three or four societies clubbed together, and sort of capacity building can be done. But government initiative, government approval is a must. Until unless that happens, nothing can be done on the ground. So higher level of advocacy, starting from such webinars, then documenting them, maybe coming up with more strong paper evidence on the international journals which are PubMed at least indexed or Q1 as per Scopus. Then talking to leaders who matter, because until unless the discussion happens in the parliament, discussion happens in the government. I think Niti Aayog is a very good start. But again, until unless the politicians, the bureaucrats, and the doctors all are three together, then there are lawyers also, because they are one of the major stakeholder of all this. Because until unless they agree to everything, the law is not going to be promulgated. So all the major leaders need to sit together at one table. Then only I think things can materialize, the amendment can be done, etc., etc. So it's a long walk. It's an arduous task. Time is long, but life is short, as we say, as we know. Art is long, time is short. But definitely it's a start, and I'm pretty hopeful that this start will achieve what we have started to set out. Thank you.
Yes, sir. Thank you, sir. Bala sir, would you like to ask any more questions, sir?
I think it's been a very fruitful webinar with several points emanating, which is of great relevance. And I think the most important thing now is to, based upon all the insights which we got from such resourceful, experienced and people, and we will create a white paper and share it with all the panelists, get their insights and inputs, and also create a pathway of to move forward, timelines to be made. And as Dr. Vijay Agarwal and Dr. R.K. Mani had mentioned that we will have to make it, we need to lobby for this. I think this webinar is a beginning of that journey, and I'm sure that with same enthusiasm, we need to pursue this. And I think it was an excellent panel discussion. Thanks to 4 experts who brought in to the light in this panel discussion. Thank you, sirs. Over to Dr. James.
Yes, sir. Thank you, sir. Thank you, Vijay sir, Mani sir, and Joshi sir, as well as Rana sir, for your insightful thoughts and deliberations, which have provided us some crucial points for us to think over and then to take it up forward. Now we will just quickly move on to the Q&A, because I see several questions. I think many of the questions are already answered during the panel discussion, so I will just skip those. I will just ask a few questions which we have not addressed. Do we need to register, Rana sir, this is for you, sir. Do we need to register MRI machine under PCPNDT Act if MRI machine is used for fetal imaging to assess congenital anomalies, etc.?
Can you just please repeat the question briefly?
Sir, do we need to register MRI machine under the PCPNDT Act if the MRI machine is used for fetal imaging to assess congenital anomalies?
I think the PCPNDT Act says about any machine which is going to be used for fetal sex determination, or it can be used for sex determination. So if the MRI being used can determine the sex, then definitely it will have to be registered. This is my understanding of the act. I don't know whether I'm very correct or very wrong. I can't say. Determine the sex of the fetus, then definitely it will have to be registered, because the law is very clear. As I said, any ultrasound determine the sex of the fetus needs to be registered. It is written there.
Sure, sir. Thank you, sir. Now, Pratibha Kane, ma'am, can I ask one question to you, ma'am? Participant has asked, is it mandatory to register all doctors, including specialists like endocrinologists and physicians, who use ultrasound machines for diagnostic purposes such as thyroid or abdominal screening under the PCPNDT Act?
Ideally, yes. Ideally, yes. Yes.
Sure, ma'am. Thank you.
Actually, the hospitals means it is, we have to ask the hospitals to see that our name is in that PCPNDT. If you're touching the ultrasound probe, it is better that you have said that you are qualified, you have that 6-month training, and you are qualified. It must not be seen that you're not qualified to use the ultrasound machine. What happens once you are registered with the ultrasound PCPNDT, that they check your qualifications and they say you are qualified to use the ultrasound machine.
No, ma'am. Ma'am, along with that, there is one question related to this, privileging, kind of a privilege question, which asks, one participant has asked, do we have some basic requirement for anesthesiologist for registering under the PCPNDT Act beside our basic qualification? Or are they rephrasing to the same? One more person has asked, do we need to submit any certificate of USG learning separately?
I think
no, because it comes in our curriculum, so you don't have to. But the ideal process is that you have to give a personal declaration that you will not use this ultrasound for any sex determination, and we are not qualified in doing any obstetric ultrasound. Okay, so for anesthetists to do obstetric ultrasound is illegal.
Tom. Rana sir, I have one more question for you. Can we register at multiple hospitals or in different states simultaneously?
I think one district, 2 sites.
Sorry, sir?
One district, they can register for 2 sites in one district.
Okay, within the district, they can register at 2 sites. That's what you're saying. Yes, sir. Thank you, sir. Thank you. So, Bala sir, I think we have covered almost everything. So, shall we wrap it up, sir?
Yes, I think it was absolutely a worthy session, an eye-opening session, a very pertinent session, and I think we are very happy. I think we'll wrap it up and
Yes.
over to you, Dr. James.
Yes, sir. Thank you all the panelists. Thank you, Kane ma'am and Rana sir, for
Thank you,
your
James, and
insightful.
thank you,
Thank
Dr.
you.
Balvenkat.
Thank you, Bob.
Yes.
Thank you, James.
Thank you,
Thank
sir.
you,
Thank
panelists.
you, sir. Thank you, sir.
We'll
Now
have
I
the
will
official vote of thanks. Yeah.
Yes, I will
Thank
hand
you,
over
sir.
the podium to Danya for vote of thanks.
Thank you, James. So on behalf of CAHO, I extend our sincere thanks to all panelists and participants for making today's session very impactful. We as a team is grateful to Dr. Vijay Agarwal and Dr. Lalu Joseph for their visionary leadership and support, and to all ISA members for their enthusiastic participation. A heartfelt appreciation to Dr. Bala and Dr. James for their outstanding coordination of the entire event. Special thanks to Meenakshi and Nisha from CAHO Secretariat for their help and support for this program. Thank you all once again. Over to you, Dr. Manoj.
Thank you. Good evening, everybody. As we come to the end of the webinar on PCPNDT Act, it is my duty to deliver the vote of thanks to all those who helped to make today's event. First and foremost, I would like to express my gratitude to CAHO for the taking the initiative and collaborating with ISA and CISA. Express my deep felt thanks to Dr. J. Bala Venkat Subramaniam sir, President ISA National, Dr. Vijay Agrawal sir, President CAHO, Dr. Sukhvinder G. Singh Bajwa, Honorary Secretary ISA National, and Dr. Lalu Joseph, Secretary General CAHO, for all the effort taken in the organization of webinar on PCPNDT Act, Therapeutic Care, and Roadblocks and Way Forward. I would like to thank to all the speakers, Professor Om Prakash V. Nandinath sir, Dr. Rajiv Joshi sir, Dr. Rajat Mani sir, Dr. J.V. Divatia sir, Dr. Naveen Malhotra sir, Dr. Sukhvinder Jeet Singh Bajwa sir, Dr. Srinivas Salu sir, Dr. Rishabh Kumar Rana sir, Dr. Danya Michael madam, Dr. Ranjit James sir, Dr. Pratibha Kane madam, for sharing their insight and valuable thoughts on PCPNDT Act, Therapeutic Care, Roadblocks, and Way Forward. I thanks our all the ISA members who registered and attend the webinar and participated in the discussion. Thank you once again to all of you. Long live ISA. Thank you. Over to Danya madam.
Danya, you're muted.
Yeah, thank you once again, each one of you, Bala sir, Venkat, James, and entire CAHO team. That's it, we have done. And let's proceed with the rest of the requirement, including the white paper requirement as we have discussed. Over to you, James and Bala sir, for concluding the session.
Yeah.
Thank you.
Thank you so much. And we look forward to making this more impactful and fruitful. And we look forward to creating timelines, and we'll accomplish all of our aspirations and dreams. Thanks to all. Thank you, Dr.
Thank
James,
you,
for
sir.
this
Thank you so much.
wonderful coordination, and all the experts for their brilliant ideas. Thank you.
Thank you, sir. Thank you, everyone. Have a great night.
Thank you. Bye-bye. Good night. Thank you.
Good night. Good night.